Hello, everybody. We're going to talk about keratopathy in thyroid eye disease. This is my only financial disclosure. We'll begin with the case. This was a young female who presented to us several years ago. Severe ocular surface changes. The clinical picture was suggestive of a burnt out thyroid eye disease, and she had barely perception of light in both eyes. The CT scan was suggestive of a fat predominant disease and an optic nerve stretch. We attained euthyroid status, and then orbital decompression was done sequentially, followed by eyelid surgeries. In the right eye, for the corneal scar of right eye, penetrating keratoplasty was done, followed by cataract surgery, and she attained a 20/50 vision in the right eye. Quite unimaginable if we look at the clinical presentation. Keratopathy in thyroid eye disease could present in the form of punctate epithelopathy to corneal clouding to a full-blown microbial keratitis with or without decimetocele. The ocular surface disease has quite a high prevalence in thyroid eye disease. And depending upon whether we take subjective or objective criteria, almost 2/3 of patients with thyroid eye disease have an ocular surface problem. This kind of a milieu may be the setting to cause more fulminant corneal breakdown. If we try and understand the pathogenesis of ocular surface disease in TED, what is often talked about is about surface exposure or even altered blink dynamics. But new evidence has emerged in the literature which suggests that there are alterations in the tear film characteristics, rather in all layers of the tear film, in the meibomian gland architecture and dropout, and interestingly, cytokines predominantly pro-inflammatory in the tear film, which correlate well with the activity of the disease. In this setting, it's important to understand that from a common change in the ocular surface milieu, we have a full-blown keratopathy and corneal breakdown. If we look at the evaluation of ocular surface in thyroid eye disease, most classification systems are restricted to looking at stippling of the cornea to ulceration to perforation of the cornea. What is probably needed is a more elaborate evaluation of the ocular surface, both subjective, could be in the form of OSDI questionnaire, two objective parameters like the tear breakup time, Schirmer's test, tear film osmolarity, and cytokine levels. Imaging is, of course, useful in a setting where additional dysthyroid optic neuropathy is suspected. In patients with microbial keratitis in one eye, it's always challenging to grade severity. We have, for quite some time, used the fellow eye to grade the severity. Alternatively, one can also use an MRI hyperintensity or signal intensity ratios, which has a close correlation with the activity of the disease. In the setting of apical crowding, of course, imaging becomes extremely useful. There is sparse information about microbial keratitis in TED, and two large series have been published. One from our own institute showed a 1.3% prevalence of microbial keratitis. 92% were active, most were moderate to severe disease, and none had microbial keratitis with DON. Unfortunately, a large majority had poor visual recovery, and 4 needed evisceration. Another large series published from over 2 decades of experience with TED showed less than 2% had corneal ulcers. Here, however, 50% had associated dysthyroid optic neuropathy. Again, suboptimal visual recovery and aggressive therapy was necessary in management. Risk factors for keratopathy have been elusive, and our own experience with 202 patients showed that while smoking, systemic disease of diabetic mellitus, and older age were clear risk factors for DON, none of them were significant for corneal breakdown. If we talk about managing keratopathy, one has to probably use one of the existing severity scales to put the patient into either the mild or the moderate to severe types. In the milder versions, medical therapy of lubrication, moist chamber glasses are usually enough. Whereas in moderate to severe types, one may resort to either topical cyclosporin, topical steroids, and liberal usage of tarsorrhaphy to protect the surface. What is very much needed is a more elaborate evaluation, as mentioned earlier, about the ocular surface and to look for risk factors. In full-blown corneal breakdown in inactive disease, one has to give a tectonic support in the form of amniotic membrane graft or a cyanoacrylic glue, followed by definitive surgery. However, in active patients, stabilization of both the general disease and the ocular disease are both important before definitive surgery. In recalcitrant ones, emergency decompression and eyelid surgery becomes necessary. This lady presented with a full-blown microbial keratitis with a fungal cultures in the left eye with a contraindication for corticosteroids. She underwent a bilateral decompression and tarsorrhaphy in the left eye. And this is 1 week after surgery, showing stabilization and resolution of the disease. To summarize, keratopathy has a fairly common prevalence of ocular surface disease in almost 2/3 of patients, and few of them develop corneal breakdown, and this is about less than 2%, but a significant and a sight-threatening complication, as we know. New information in changes related to tear film, corneal biomechanical properties, and pro-inflammatory cytokines is key to understanding the pathogenesis of corneal breakdown and ocular surface milieu in thyroid eye disease. Unfortunately, a large majority of those with corneal breakdown have poor visual recovery, necessitating aggressive therapy. We feel that evaluation of the ocular surface needs to be more elaborate in TED, and much needed at this time are risk factors predicting progression to corneal breakdown. Therapy in keratopathy in thyroid eye disease setting has to be individualized. Thank you.